Hello, my name is Dr. Robert Frank. I'm a pediatric infectious disease physician at Cincinnati Children's Hospital and the medical director for the Teenage Immunization Education Sessions, or TIES. Today what I'm going to do is to give you an overview of the TIES program and focus on the immunizations that we would like adolescents to receive. TIES is provided by the Ohio chapter of the American Academy of Pediatrics with funding by the Ohio Department of Health with a federal grant with the Centers for Disease Control and Prevention. I have no financial relationships to disclose, and there will be no off-label products discussed in this presentation. This is to remind you that there are continuing medical education credits available for this presentation. The Ohio chapter of the AAP is accredited by the Ohio State Medical Association to provide continuing medical education for physicians. The Ohio AAP designates this activity for a maximum of 1 AMA PRA Category 1 credit. Physicians should claim only the credits commensurate with the extent of the participation in the activity. The missions and objectives of the talk are outlined in this slide. The objective is to describe diseases prevented through adolescent immunization, review immunization schedules for adolescents, review issues related to vaccinating adults such as strategies and safety, discuss TIES best practices, and introduce the Plan, Do, Study, Act worksheet. To start the presentation, I'd like to review what's new for 2017. The first is the HPV vaccine 2-dose schedule. Previously, all people required 3 doses of HPV to be fully immunized. However, now 2 doses is all that's required if adolescents start the immunization series between 9 years and 14 years of age. However, if they're 15 years and older when they start the series, they still require 3 doses of HPV vaccine. Also, as of January 2017, the 9-valent HPV is now the only HPV vaccination available in the United States. And for meningococcal vaccinations, there was the Ohio meningitis bill that requires the quadrivalent or meningococcal ACWY for children in the 7th and 12th grade as of fall of 2016. Lastly, the Meningococcal B Vaccine was approved in 2015 by the ACIP with a Category B or a permissive recommendation. In this slide, we're presenting you the recent updates for adolescent vaccination rates in Ohio and the United States for the selected adolescent immunizations. The vertical axis is percentage from 0 to 100, and the horizontal axis is the different vaccines of Tdap, the quadrivalent meningococcal vaccine, HPV in females, and HPV in males. The first column is the objective for the CDC to the minimum immunization rates, and then the next 2 bars are the actual immunization rates in the United States and then the actual immunization rates in Ohio. What you can see by this slide is that both Ohio and the United States are doing well for the goals for the Tdap and the meningococcal quadrivalent vaccine. However, for both the HPV in females and HPV for males, the actual immunization rates fall far below the desired immunization rates. This slide demonstrates the 4 vaccines that are recommended for all preteens at age 11 to 12 years. The first column shows ages in years from 7 to 8 going to 16 to 18 in the last row. And then the next column is the flu vaccine, the Tdap, the HPV, and then the meningococcal quadrivalent vaccine, the meningococcal B vaccine. The green means that it's recommended, and the yellow-orange is the catch-up period. So if you look at 11 to 12 years of age, that's, if you will, kind of the sweet spot where we would like to get all adolescents or pre-adolescents immunized against flu, Tdap, HPV, and meningococcal quadrivalent. The purplish means that it's a allowable vaccine if they're in high-risk groups. So the first disease we're going to talk about is HPV, or human papillomavirus. There's more than 120 types of human papillomavirus, and has now been established to be the cause of cervical and other anogenital cancers. It also is known to be the major cause of head and neck cancers. And according to the World Health Organization, in 2012, approximately 270,000 women died of cervical cancer. Besides cancer, HPV is also the cause of genital warts, a significant cause of morbidity in teens and young adults throughout the world. HPV is the most common sexually transmitted pathogen in males and females. There are 14 million new infections in the United States annually, and it's estimated that 79 million people are infected. The highest prevalence of HPV is in sexually active adolescents and young adults. And we know that the first infection occurs soon after the onset of sexual activity, with approximately 30% of girls having evidence of HPV within 6 months of onset of sexual activity. Here we have some new data that was released in January 2017 to really emphasize the importance of immunizing males against HPV. While both 45% of U.S. men and women are infected with HPV, men are more likely to stay infected throughout their lives. It's not certain why that is, but we think it may be due to the number of partners or new partners throughout the lives of males, and that there continues to be exposure to HPV due to the new partners. Also, there seems to be a lower HPV immune response to natural infection in men than in women. So the conclusion of this data is that male HPV vaccination may have a greater effect on HPV transmission and cancer prevention in men and women than previously estimated. So what we're trying to emphasize here is that while vaccination in women is certainly important, it's also critical to immunize men. Here we're looking at the different HPV-associated cancers. There's approximately 31,000 new cancers attributed to HPV annually in the United States, with 19,200 in women and 11,600 in men. And while HPV-associated cervical cancer is the most common cancer associated with HPV, the number 2 is oropharyngeal cancer in men. And then number 3, anal cancer in women. And this slide is pointing out in a very important point, is that it's predicted that the annual incidence of HPV-related oropharyngeal cancers is expected to surpass the annual number of cervical cancers by 2020, despite the availability of an efficacious prophylactic vaccine against HPV. Now there's 2 points here. One is that the HPV vaccine has been shown to be decreasing cervical cancer rates already, so that's one reason that the oropharyngeal cancer would be exceeding the cervical cancer. And the other is that men just do not get vaccinated as often as women. So again, the point is how important it is to be vaccinating everyone. This slide is looking at how quickly we can see an impact of the HPV vaccine as evidenced by HPV prevalence in children and young adults within years of starting the HPV 4-valent vaccine. So that within 3 years of starting the vaccine, there was a 64% decrease in HPV 6, 11, 16, and 18 in girls 14 and 19 years of age, and a 34% decrease in women 20 to 24 years of age. This is despite vaccination rates only in the 30% range. Now, the reason why we think it's a bigger decrease in the younger age is because they've never been infected with HPV, and therefore you get a bigger impact of the vaccine because this vaccine is prophylactic and not therapeutic. So once you've been infected with HPV, the vaccine cannot prevent against that serotype, and therefore you would not expect it to decrease the rate of infection with that serotype. Here we're reviewing the HPV vaccination recommendations for adolescents. It's recommended for routine vaccination at age 11 or 12 years of age, but vaccination can be started as early as age 9. Females aged 13 to 26 and males aged 13 to 21 not adequately vaccinated previously also may be vaccinated. And and vaccination can continue through 26 years of age for men who are having sex with men, transgender people, and immunocompromised persons, including those with HIV infection who have not adequately been vaccinated previously. So while we are targeting the 11 to 12 year group, we really want everyone to be vaccinated in this range from 11 up to 26. And ideally, vaccination should begin before people are exposed to HPV, which is why we're looking at immunization at the 11 to 12 year range. However, people who have already been infected with one or more HPV types can still gain protection from other HPV types in the vaccine. And from data we know in clinical trials that less than 1% of subjects had previous exposure to all 4 serotypes of HPV. So even if there's been exposed to one, they oftentimes can still get protection against multiple other serotypes. Previously, there were 2 formulations of the HPV vaccine, the 2 and the 4-valent. However, as of January 1st, 2017, only the 9-valent or 9V-HPV is available in the United States. If a series was started with the 4-valent HPV or 2-valent HPV, the series can be completed with a 9-valent HPV vaccine. However, there is no ACIP recommendation, that's Advisory Committee for Immunization Practice recommendation, for giving the 9-valent HPV vaccine to persons who have completed a series with the 4-valent or 2-valent HPV. However, it's safe to give the 9-valent HPV to people who have completed an HPV vaccine series. So if someone were to come into the office and request a dose of the 9-valent, it would be fine to give them that, and there are no safety concerns. However, there is no recommendation to routinely give a booster with 9-valent HPV. This slide is giving a little more information about the new 2-dose schedule. On the left, that you'll see the series for if the patient's less than 15 years of age at the time of the first dose, and that'll be a 2-dose series. The first dose is given at time 0, and that's we refer to as a prime dose, and then the boost dose is 6 months later, and that the range is 6 to 12 months after the first dose. And the reason we put 6 to 12 months, we've actually found that the longer you go after the first dose, the better your immune response, but we need at least 6 months. My suggestion would be, though, is if you have an adolescent in your office and they're 6 months or more for the first dose of HPV, just give them the second dose, because it is often hard to get the adolescents into the office to immunize. On the right is the data or the series for the 3-dose series. And you'll still need to use the 3-dose series if the patient is 15 years of age or older at the time of the first HPV vaccine, if the patient has an immune-compromising condition that might affect the cell-mediated humoral immunity, or if the patient was younger than 15 years at the age of the first dose, but received a second dose earlier than would be acceptable for 2-dose series. So if they received the first dose at 14, but then they got the second dose only 1 month later, that's not 6 months between the first and second dose, and so they have to get that third dose at least 4 months after the second dose and at least 6 months after the first dose. This slide is providing data as to why it's important to immunize early against HPV. The slide is showing the percentage of students in Ohio who self-report having had sexual intercourse for the first time before 13 years of age. The vertical axis is percent from 0 to 20, and then across the horizontal is first the total, then males or females, and then the different years in school when they were surveyed about their activity at 13 years of age. So what you can see is it's approximately 4 to 5% of students said that they had initiated sexual activity by 13 years of age, and that's why it's really important to immunize early. This slide is some other data from Ohio that's looking at the number of students who had sexual intercourse with 4 or more people during their lifetime. And again, it's the percentage from 0 to 45% here, and then the total, the females, the males, and the different ages or grades in school. So as you can see, by the time their students are in 12th grade, approximately 20 to 30% of the students self-reported having had sexual intercourse with 4 or more people during their lifetime. And the more people that you've had sex with, the more likely you're going to acquire HPV. And so this is another reason why it's important to immunize early against HPV. Here we're presenting some data about a study looking at the relationship of HPV vaccine to sexual activity. Because one of the major concerns we've heard from families is that they're afraid as if they give their children the HPV vaccine that they will become sexually active. In this study, there were 1,398 girls. 493 received the HPV vaccine, and 905 had not received the vaccine. It was a retrospective cohort study that looked at outcomes 3 years after vaccination. So what they did is that they looked at day 0 and then followed for the next 3 years after vaccination or not vaccination to see if there was any difference in sexual activity, as looked at surrogate markers as far as sexually transmitted diseases, pregnancy testing or counseling, and contraceptive counseling. And what they found, there was absolutely no difference in the rates between the girls that received the HPV vaccine and those that did not receive the vaccine. And so the take-home message here is the vaccine did not lead to the change in any sexual activity or increase in sexual activity. So these are some questions we have received about the HPV vaccine and if it's still okay to vaccinate. And so yes, it's still okay to give a vaccine even if there's a history of genital warts, there's a history of abnormal pap smear, the patient is immunocompromised, or a female patient is breastfeeding. This is a killed vaccine and it will not give anybody the infection, and it is not at risk for someone that's immunocompromised. Here's some other data to hopefully be reassuring for your patients about the HPV vaccine, and that is that the HPV vaccine is safe. As of September 2015, over 86 million doses of the HPV vaccine have been given in the United States. 3 population-based safety studies have been conducted in the United States to date, and no serious safety concerns were noted. The major side effect of the HPV vaccine has been syncope, and that's really not unique to the HPV vaccine, and it's thought to really be a combination of a pain response and just fright from the needle and a vaccination. So the most common side effects in clinical trials were fairly minor, of fever, nausea, dizziness, injection site pain, swelling, erythema, pruritus, and bruising. And this really was the exact same percentage we see with other vaccine studies, and there was very little difference from the placebos. Now we'll turn our attention to meningococcal disease, a bacterial infection that can be very serious throughout the ages, but we are concerned because there is a small blip of disease within the adolescent age range. This slide shows the meningococcal incidence by serogroup and age group in the United States between 2005 and 2013. The vertical axis shows the incidence per 100,000 ranging from 0 to 2.5, and then the horizontal axis is breakdown by years. The yellow color is the percentage of meningococcal disease caused by serogroup B, and the blue is the amount caused by serogroup A, C, W, and Y. And so what this slide shows is that the majority of meningococcal disease occurs in the first year of life, and that about 60+% of the disease is caused by serogroup B. After 1 year of age, there's a significant drop-off in the incidence of meningococcal disease until we hit around the 18 to 22 year group, when they start to have a small increase again, followed by another drop-off of the disease. The risk factors for invasive meningococcal disease include immunodeficiencies, example being no spleen, HIV infection, family members in an affected person, smoking or passive exposure to smoke, having an upper respiratory tract infection in the past week, crowding, or college students living in a dormitory, which in effect is the same as crowding. The recommendations for the quadrivalent meningococcal vaccine for adolescents is to have 2 doses for adolescents aged 11 through 18 years, with the first dose at 11 to 12 years of age and a booster dose at 16 years. For an adolescent who received their first dose of meningococcal quadrivalent vaccine on or after age 16, they do not need a booster dose. Last year, the Ohio Senate passed what was called the Ohio Meningococcal Law. This is a new mandate that began in 2016-2017 school year, and it requires students to be immunized against meningococcus. The bill requires 1 dose of the quadrivalent vaccine be given in the 7th grade and a 2nd dose given in the 12th grade. Like the recommendation in the ACIP, if the first dose of meningococcus vaccine was given after the 16th birthday, a 2nd dose is not required. And while this is a required shot, the legislation still allows for medical and personal exemptions. There also exist other laws about meningococcus in Ohio, and for college, legislation was passed in Ohio in 2005 that requires students at least to provide vaccine status information. And on top of that, some institutions have their own requirements for incoming first-year students living in residence halls or for incoming first-year students. So it would be a good idea for your patients to check their particular school, because some schools do require the meningococcal vaccine for admission. Adolescents with certain medical conditions have a different recommendation for vaccination, and they require a 2-dose primary series. And this would be for adolescents who have HIV, asplenia, or complement component deficiency. And these patients, after their 2-dose primary series, would still receive the booster later in adolescence, and then every 3 to 5 years while they continue to have the immunocompromising condition. In October 2014, the FDA licensed the first serogroup B meningococcal vaccine, abbreviated MenB FHBP, as a 3-dose series. And 2 years later, in April 2016, the FDA approved a 2-dose schedule for this same vaccine. In January 2015, a second meningococcal B vaccine, abbreviated MenB4C, was licensed as a 2-dose series. And both vaccines were approved for use in persons 10 to 25 years of age. In February 2015, the Advisory Committee on Immunization Practices, or ACIP, recommended use of meningococcal B vaccines for children greater than or equal to 10 years of age at increased risk for meningococcal B disease. So those things we discussed before: HIV, complement deficiency, and asplenia. The same product should be used for all doses because these 2 meningococcal B vaccines are quite different in their construct. In June 2016, the ACIP provided updated recommendations stating that meningococcal B series may be given to anyone 16 to 18 years of age. And while the vaccine is approved, it also has a permissive recommendation for ages 10 to 25, but there's not a recommendation for routine use in children through young adults. And the reason for this is we're still trying to figure out the exact efficacy of the meningococcal B vaccine, along with the epidemiology of meningococcal B disease decreasing in the United States. Hopefully over the next few years we'll have a little better information and can give an updated recommendation on meningococcal B vaccine. So at this time, the permissive means that you can give it and there's no safety signal, but it's not required for all children. We'll now move on to pertussis and specifically focus on pertussis among adolescents and adults. Pertussis in this age group still has a prolonged cough, oftentimes of 3 months or longer, and many complications including pneumonia and rib fractures. Hospitalization is not that uncommon. Missed school and work is common, with up to 2 weeks of school missed in some cases, and an impact on the public health system of requiring many medical visits if there is an outbreak of pertussis in the community. Many times there's similar symptoms in adolescents that there are in younger children, such as the whoop and the vomiting after prolonged coughing. Due to the prolonged coughing and feeling ill, there's oftentimes weight loss and then multiple medical visits and extensive evaluations due to misdiagnosis, oftentimes thinking that the child has allergies or asthma instead of pertussis. The loss of sleep is common, with many adolescents reporting over 2 weeks of sleep disturbance. And then one of the main problems is that adolescents are the second highest group of transmission of pertussis to infants, and this is why it's really needing to immunize the adolescents against pertussis. So this slide is looking at the incidence of pertussis, or excuse me, the number of cases of pertussis in the United States, and specifically in Ohio. And in 2011, we had 690 cases, but every year over the next 3 years, we've had increases, and in 2014, there were almost 1,500 cases reported in Ohio. So if there's 1,500 cases reported, there's probably 10 or 20 times that number that actually occur. The protection provided by the Tdap vaccine wanes, and that's why adolescents need the Tdap as a booster. And it's thought that increasing Tdap immunization rates among adolescents is an important strategy for reducing pertussis among adolescents and infants too young to be fully immunized. The recommendations for adolescent Tdap vaccination is to receive a dose at 11 to 12 years of age, or 13 to 18 years of age if they did not receive it at 11 to 12. The Tdap should be administered regardless of the interval since the last tetanus or diphtheria toxoid-containing vaccine, and this is a change from when the Tdap initially came out. We had a recommendation to not give the Tdap closer than 18 months to 2 years after a DT-containing vaccine. However, we've now found that that's no longer necessary, and so that if a child comes into your office and needs a Tdap, even if they've had a DT shot in the ED less than a month ago, go ahead and give them the Tdap, it'll be fine. Also, that the Tdap vaccine can be administered at the same time as other adolescent vaccines, and there's no reason to withhold the vaccines. Basically, if an adolescent needs a vaccine, give them all the vaccines they need at that visit, because it's very difficult to get adolescents into the office. We'll now move on to our last topic, which is influenza. And flu can be a serious illness even for healthy adolescents. And in our hospital this year, we've had many children admitted to the ICU for flu, and that adolescents with high-risk conditions are more likely to suffer flu complications. And one of the things too is that flu seasons are unpredictable and can be severe. And this year in particular, we're seeing a lot of cases of flu, even though the vaccine is well matched. And part of the problem is that we just didn't get a good number of people vaccinated this year so far. So who needs an annual flu vaccine? Well, basically everyone 6 months of age and older. We now have a slight update in the flu vaccine to a quadrivalent, which has 2 A strains and 2 B strains, and that's different from the typical that we had been using, which is a trivalent, which had 2 A strains and 1 B strain. And that we added the extra B strain because we have found that more flu is caused by B than we initially recognized, and we are very bad at predicting which strain of B will be circulating, so we just put both of them in the vaccine. The flu vaccine is only available as an inactivated flu vaccine this year because the live attenuated flu vaccine was removed from the market due to lack of efficacy. So one of the things that's important to do every time a child comes in for a vaccine is to screen for contraindications and precautions. The good thing is there's very few that are things that are true contraindications or precautions. But every time you should ask the screening questions about the vaccines. And the only true contraindications or precautions should limit vaccination. And one of the things that's new for this year is that egg allergy is no longer a contraindication to receiving flu vaccine. And that was done because it was found there was so little amount of egg protein in the flu vaccine that it did not cause a problem even in people that had severe egg allergies. So the contraindications to vaccines are severe allergic reaction to a vaccine component of following a prior dose, or an encephalopathy not due to other identifiable cause, which occurred within 7 days of pertussis-containing vaccine. And this is really quite rare, but if you would have somebody that had a encephalopathy within 7 days of pertussis-containing vaccine, do not give them additional pertussis. A precaution would be a moderate or severe acute illness, and with that, then we would just recommend to defer until the symptoms have improved. But it's not a total contraindication, it's just a delay until they get better. One of the things that we found is that the most common adverse event in adolescent immunization is fainting, and that can occur after any medical procedure, but we have found an increase after vaccination, and it's been particularly prevalent after HPV because many girls complain about the pain. It seems to be actually more girls complain than boys, and there may be actually some genetic difference, but anyway, it's typically been a rapid fainting after the administration of the vaccine. Because of that, we recommend that adolescents should be seated or lying down during the vaccine, and then consider having your patient stay for at least 15 minutes after vaccination. The other thing about vaccine safety is that Vaccine Adverse Event Reporting System, or VAERS, and this is a volunteer reporting system for anyone and who thinks that there's been an adverse event associated with a vaccine. All we ask is that to report the information you know, and then the CDC will look into it further. It's not that you have to prove that it's an adverse event, but it's just you would suspect that it's an adverse event related to the vaccine. So this slide is just trying to remind us that what convinces parents to have child receive their vaccines if they were hesitant about getting a vaccine. And the vertical axis is the percentage of parents, and then the horizontal talks about the different ways that parents can receive information. And the number one way that the parents are convinced to have their child receive vaccine is the information and reassurance they get from healthcare providers. So it's even though we don't think about it, is that we still have a lot of influence on our patients, and that we should give them a strong message that vaccines are important. One of the things that we found has been very helpful to talk to parents about vaccines, and the immunization education should include both the benefits and risks associated with the vaccine, and then aftercare instructions for managing side effects. One of the easy ways to be able to do this is to use the vaccine information statement and give that every dose of vaccine is administered, every time a vaccine dose is administered. And these are very nice information handouts that give simple language about the vaccine and the benefits and risks of each vaccine. The other thing, it's important to administer all the needed vaccines at that visit, and ensure that your vaccines are prepared and administered correctly, and that the Tdap, the Meningococcal, quadrivalent, and HPV can be administered during the same healthcare visit, and you can also give flu if it's during the flu season. That the other thing to do is you can review the immunization schedule, and if for some reason a child missed a vaccine earlier in life and is required the vaccine still, go ahead and administer that vaccine too. There are required documentations associated with administration of vaccines. First, that you should document your immunizations in the medical record and an immunization information sheet. And the federal law requires that all immunization providers document in their charts the date the vaccine dose was given, the date the vaccine information statement was given, the date on the VIS, the vaccine manufacturer, the vaccine lot number, and a signature of the person administering the vaccine. It's also best practice to record this information in the patient's chart and to give them a vaccine record so that they can take with them. Things that we've found to help improve vaccination rates are utilizing a tracking system and a reminder and recall. And so a reminder is to let somebody know before the vaccine is due, and a recall is that after a vaccine's been missed, to let them know they missed a vaccine and they need to come in and get it. And that there's been a number of studies and shown that the system that has worked the best, and is not surprising, is texting to both the adolescent and the parents. The other things that we found that help is having standing orders in the office to allow nurses to give vaccines, and then at the time that the adolescent leaves the office, to schedule the appointment for the next dose, so that they already have that in hand when they leave the office. Another thing that's helped too is just to have vaccine-only visits or even night hours where the adolescent can come to get the vaccine. Other consideration for providing vaccines to adolescents is to make sure that you check at every visit to see if someone needs a vaccination. And that research has shown many times over that there's patients come in and they've had missed opportunities. So they come in, they need a vaccine, it wasn't given, so they leave and they're still not immunized. And so if you check a vaccine status at each visit, that it has significantly increased the compliance with multi-dose regimen schedules such as the HPV. And whereas one study where the practice was able to get 73% of the adolescents to get all 3 doses of HPV on time by using the missed opportunity, so that giving the vaccine anytime somebody comes in. And one of the things that's mentioned again is that provider recommendation is the strongest predictor of vaccination. So if you come in and say, we have 4 vaccines to give today, we have the Tdap, the meningococcal quadrivalent, the HPV and flu, and all of the vaccines are important, none are more important than the other, that just gives the idea to the parents that they need to get those vaccines. Many times we've seen that physicians have given a half-hearted recommendation about HPV, and the parents pick that up and then do not get their children vaccinated against HPV. So we just recommend that you really just need to give a very strong message about the importance of vaccine and that all of them are needed. As we talked about before, is implementing a reminder recall system for every patient. And the other things that we found that's helped for vaccination rates is to have someone in your office that's the go-to person. They're the vaccine guru, and it doesn't have to be the doctor. It can be a nurse or even one of the aides if they have sufficient information. That make sure that you give all vaccines that are due regardless of the number of injections, and allow shots to be given to adolescents with minor illnesses like colds or diarrhea, low-grade fever. This will not increase the adverse events by giving the vaccines when they have mild illness, but it will significantly increase the likelihood of completing vaccinations. And give age-appropriate vaccines even when no vaccine record is available. The worst that happens, they get an extra dose of vaccine. You should screen for valid contraindications and precautions, but as I mentioned before, they're very rare, so it's very unlikely that you're going to have an adolescent that has a true contraindication to a vaccine. And this is another slide talking about best practices for office operations, and that the Academy of Pediatrics and TIES offers an assessment feedback incentive exchange, or AFIX measurement, to look at the immunization rate within your past year to give you an idea as to how well you're doing and if there's a way that you can improve. And this is a confidential evaluation. The information is not shared with other practices, it's not shared with the CDC, so that it is confidential to your practice. Also become a Vaccine for Children provider. That way that you can get vaccine free of charge for children that qualify for the program. Make sure that you provide a current VIS to parents prior to immunization at every visit and allow them to take that VIS statement home. Have a written plan for protecting vaccines in case of a power outage. You hope that you never have a power outage, but you don't want to be trying to figure out what to do at the time a power outage occurs, so have that plan in place. Use the IMPACT-SYS registry to check your immunization status and enter immunization information. If we can get a large percentage of people to use this system, it really will significantly improve our vaccination program, because we can then check from program to practice if the child has been immunized and help the provider know what vaccines need to be provided. As I mentioned before, check the vaccine status at every visit and have materials available to address vaccine concerns. And your MOBI trainer or TIES trainer will be able to provide you handouts from the Academy of Pediatrics on concerns about vaccines that parents have raised. So that's the end of our discussion, and so now I'd like you to please fill out your post-survey questionnaire and evaluation to receive your CME. Thank you very much for your attention, and I hope you enjoyed this presentation.